Patients here.
Oh boy, got some blood going.
Yeah, there's blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver of a vehicle, appears that she went off-road into a ditch, rolled over her car into a tree, caved in, the top of the vehicle was caved in, so she was hanging out partially from the window. She's been in application
for 45 minutes of CPR. We can stop CPR with 600, 600, 600.
You know, usually when we talk about a medical diagnosis, there's this expectation of like precision. It feels almost like engineering.
Right, yeah, like fixing a machine.
Exactly. You break your arm, the x-ray shows that jagged white line, and the doctor just points at it and says, you know, there it is.
It's totally binary. Broken or not broken,
Yeah.
it's visible, and I think that visibility is really comforting for a lot of people.
But then you step into the world of neurodevelopment or psychological trauma, and suddenly that x-ray machine is completely useless. We're looking at a diagnostic landscape that is just the absolute definition of muddy waters.
Well, absolutely. The muddiest.
And today we are shining a very bright light directly into that mud to look at one single highly complex medication. We're talking about paroxetine.
A really fascinating one.
So if you're navigating clinical practice right now, or you're just trying to lock down that crucial 20% of knowledge that yields 80% of your understanding for patient care and the NCLEX, this is the drug profile you really need to dissect. We are putting on our elite clinical pharmacist and expert nursing instructor hats today. So, okay, let's unpack this. What exactly is this drug, and how is it hacking the brain's chemistry?
Well, at its core, the generic name is paroxetine. Clinically, you're usually going to see it dispensed under brand names like Paxil or Paxiva or Brisdel.
Okay, Paxil is definitely the one I hear most often.
Right. It belongs to the SSRI class, so the selective serotonin reuptake inhibitors. And just from a baseline administration standpoint, it is not listed as a controlled substance.
Okay, so it's an SSRI, not a controlled substance. That sounds straightforward enough. But the physical mechanism, like how it actually manipulates the brain, I read that it's incredibly delayed.
It is, yeah. And that delay is where the cellular biology gets really interesting. When a patient initially takes paroxetine, the drug actually gets to work immediately by blocking the serotonin transport pump at the neuronal membrane.
Oh, immediately.
Yeah, right away. And because that reuptake pump is blocked, you suddenly get this massive pool of extra serotonin just like floating around in the somatodendritic area of the brain.
Hold on. Let's define that for a second for everyone. The somatodendritic area, we're talking about the receiving end of the neuron, right? Like the main cell body and the dendrites, rather than the axon terminals where the signals actually get sent out.
Exactly. The serotonin is pooling where the neuron receives information, but that initial pooling is literally just step one.
Right.
Over long-term use, this constant heavy flooding of serotonin causes the brain's own serotonin autoreceptors to physically downregulate and desensitize. Yeah, the neuron basically realizes there's way too much serotonin in the waiting room, so it just removes some of the doors. And it is only after that physical desensitization happens that the neuron finally allows for an increased release of serotonin at the other end.
Down at the axon terminal synapses.
Right, where it can actually influence mood.
I just love this concept. It's exactly like a clogged email inbox. At first, all these messages, the serotonin, they just pile up outside because the read button or that reuptake pump is totally blocked.
That's a great way to think about it.
But then eventually the system gets so overwhelmed by this massive pileup of unread messages that it decides to physically change its own architecture. It like alters the server to process the messages differently.
That is a brilliant way to visualize it. The brain is literally altering its own receptor architecture in direct response to the chemical environment the drug creates.
Which is mind-blowing.
It really is. And there's a critical distinguishing factor here that sets paroxetine apart from other medications in its specific class. It actually has the most potent anticholinergic activity of any SSRI.
Anticholinergic. So we were talking about the systemic drying effect. Dry mouth, constipation, urinary retention. Basically that classic can't see, can't spit, can't pee, can't poop, cascade.
Precisely. I mean, while it exhibits slightly less of this drying effect than the older tricyclic antidepressants, if you're comparing it to other modern SSRIs, paroxetine is the absolute heaviest hitter for those anticholinergic effects.
Okay, so we know it blocks the pump. It forces the brain to physically change its own receptors, and it dries the patient out in the process. What is the actual therapeutic effect we're chasing here? Like, how do we know all this internal rewiring is actually working?
Well, the expected clinical action is the alleviation of depressive or anxious symptoms. However, because that physical receptor downregulation process we just outlined takes significant time, the onset of action is notoriously slow.
How slow are we talking?
It takes 1 to 4 full weeks to see a real therapeutic response.
But waiting a month to feel better when you're in a severe psychological crisis is an absolute eternity. If the mood stabilization takes that long, what specific conditions are we actually deploying this for?
Because of that delay, paroxetine is heavily utilized for chronic, pervasive conditions rather than, acute mood crises. The primary indications cover a really broad spectrum.
Like major depression, obviously.
You're right. Major depression, generalized anxiety disorder, obsessive-compulsive disorder, panic disorder, social anxiety, PTSD, and premenstrual dysphoric disorder, or PMDD.
But those are just the on-label psychological uses because the clinical protocols reveal a couple of highly specific off-label wildcards that completely caught me off guard when I was reviewing the sources.
I know exactly what you're referring to, the urology and gynecology applications.
Absolutely. First, it is widely used off-label to treat premature ejaculation, and we aren't talking about like a subtle improvement here. The clinical data shows paroxetine increasing ejaculatory latency by up to 480%.
Yes. In the trials, patients jumped from a mean latency of about 83 seconds to well over 600 seconds.
That is a massive jump.
It's a profound physiological side effect of the altered serotonin transmission that urologists have essentially just co-opted as a primary treatment.
And the second wild card is that Brisdell formulation. That specific brand is prescribed solely to treat moderate to severe menopausal hot flashes.
Right.
But I have to push back on this one. Why are we giving a powerful psychiatric SSRI, a drug that literally alters brain architecture for hot flashes, just because a patient might not want hormone replacement therapy? Does serotonin regulate body temperature that drastically?
It is a totally valid question, and honestly, the answer in the current clinical literature is entirely unsatisfying.
No, I guess we don't know.
Exactly. The exact cellular mechanism for treating those vasomotor symptoms remains unknown. We know from the clinical trials that it effectively reduces hot flash frequency by over 60% compared to a placebo, but the exact why is still a mystery.
So we just prescribe it blindly.
In medicine, sometimes efficacy precedes understanding. It works, so we use it.
Tweaking the brain's entire thermostat to fix a hot flash or a panic attack obviously comes with massive collateral damage. That brings us to the hard lines, like who absolutely should not be taking this medication.
First and foremost is pregnancy. Paroxetine carries documented severe risks of teratogenesis.
Meaning it can directly cause fetal malformations.
Yes, particularly cardiovascular defects.
So an absolute contraindication for pregnant patients.
Unequivocally. And beyond the physical malformations, if a mother takes it late in pregnancy, the newborn is at high risk for neonatal abstinence syndrome.
Which means the baby is essentially born experiencing drug withdrawal. Tremors, high-pitched crying, irritability, feeding difficulties.
Exactly. The newborn is suddenly cut off from the continuous supply of the SSRI. There's also a risk of persistent pulmonary hypertension in the newborn.
Wait, what does that do?
Normally, a baby's lung vessels relax after birth so they can breathe air. This drug can keep those vessels dangerously constricted, preventing adequate oxygenation. It's a life-threatening complication.
Oh, wow. What about older adults or patients with organ dysfunction?
We have to be incredibly cautious with older adults and patients with severe renal or hepatic impairment. Specifically, if a patient has a creatinine clearance of less than 30 milliliters per minute, their kidneys simply cannot filter and clear this drug fast enough.
So it just builds up.
Right. For those specific patients, the maximum dose of the immediate release formulation must be rigidly capped at 40 milligrams per day to prevent profound toxicity.
Toxicity brings us right into the danger zone. We really need to talk about the severe risks, starting with the black box warning, because for a medication designed to treat depression, the highest level warning label is focused on the exact opposite outcome.
It is a really dark paradox of psychiatric medicine. The black box warning strictly states that paroxetine is not FDA approved for children under 18. Furthermore, pooled clinical analyses show a significantly increased risk of suicidal thoughts and behaviors in patients 24 years of age and younger.
And there is a very specific detail in the data I saw. The absolute risk of suicidal behavior is actually highest in young adults who are being treated for major depression as opposed to those being treated for OCD or anxiety. Why is that?
It often comes down to the delayed onset of action we discussed earlier.
The 1 to 4 weeks thing?
Right. When a severely depressed patient starts an SSRI, their physical energy and motivation often return weeks before their mood actually lifts.
No.
They're still deeply depressed, but now they suddenly have the physical energy to act on their suicidal ideation.
That is terrifying. And speaking of pediatric patients, even though it lacks FDA approval, it is sometimes used off-label for severe childhood anxiety or OCD. But there's a massive physiological risk there, too.
Yes, paroxetine can cause severe growth inhibition in children.
Like stunting their growth.
Yes. The underlying mechanism is likely due to the drug's suppression of growth hormone secretion from the pituitary gland. You are actively risking stunting a child's skeletal growth.
If a patient of any age overdoses or has a severe physiological reaction to this, is there a reversal agent, like an antidote?
No, there is no specific antidote for a paroxetine overdose. The treatment is entirely supportive, managing the airway, controlling heart rate, and maintaining blood pressure until the body eventually clears it.
So we really have to differentiate the daily expected annoyances from the life-threatening emergencies. Walk me through the common side effects versus the adverse effects that require immediate intervention.
Well, the common, mild to moderate annoyances align perfectly with that high anticholinergic profile. Somnolence, insomnia, nausea, and severe xerostomia or dry mouth.
And going back to that urological application, ejaculation dysfunction is an expected side effect too.
Right, for up to 28% of patients.
But the severe adverse effects, those require a deeper look. The data lists bone fractures, severe hyponatremia, and severe bleeding events. I understand that a psych med alters serotonin, but why does altering serotonin cause a patient to bleed or drop their sodium levels?
It's a great connection to make. Let's look at bleeding first. Serotonin isn't just a mood chemical in the brain. It is heavily involved in platelet aggregation in your bloodstream.
Wait, platelets use serotonin?
Yeah, platelets store serotonin and release it to help themselves clump together and form clots. By blocking serotonin transport with paroxetine, you directly impair the platelets' ability to aggregate.
So a minor internal bleed suddenly becomes a severe, unmanageable bleeding event because the blood literally cannot clot effectively.
Precisely. As for the severe hyponatremia, which is dangerously low sodium SSRIs, can trigger the syndrome of inappropriate antidiuretic hormone, or SIADH.
Okay, I remember this from nursing school.
Right. The brain inappropriately releases a hormone that tells the kidneys to hold on to free water. This excess water dilutes the blood, causing the sodium levels to plummet, which can lead to seizures or a coma.
That makes so much more sense. It isn't just a random list of side effects. It's a direct chemical cascade. And then you have the systemic overloads, like serotonin syndrome, which causes fever, tremors, and muscle rigidity.
And Stevens-Johnson syndrome, a life-threatening, blistering skin reaction.
Right. And to understand why this drug can be so volatile and trigger these severe cascades, we have to look at the internal traffic jam it creates, the pharmacokinetics.
Let's get into it.
Okay, I know paroxetine is widely distributed throughout the body, including the central nervous system, but the data says only 1% of the drug actually remains free in the blood plasma. If only 1% is active, how is it doing so much damage?
Because it is highly protein-bound. We're talking between 93 and 95% of the drug attaches itself to proteins in the blood.
Does it kick other drugs off those proteins?
Fortunately, no. It uniquely doesn't displace other protein-bound drugs, which prevents some interactions. It has a half-life of about 21 hours for the immediate release, and excretion is predominantly renal, about 62%, with the remainder exiting via feces and bile.
But the metabolism is where the real chaos happens. The clinical profile highlights its nonlinear kinetics.
This is arguably the most crucial pharmacological concept for paroxetine. The drug is metabolized by a very specific enzyme in the liver called CYP450. But in over 90% of patients, this specific enzyme gets completely saturated within just 10 to 14 days of starting the medication.
Okay, let's visualize this. CYP2D6 is like a specialized toll booth on the highway. Paroxetine is the traffic. For the first week, the toll booth handles the cars just fine. But within 2 weeks, the traffic volume completely overwhelms the booth. The workers physically cannot process the cars fast enough, so the booth becomes completely saturated.
Exactly.
Yeah.
And because that primary toll booth is blocked, the overflow traffic is forced to divert to a completely different highway. The body shifts the metabolism of the drug, over to the CYP3A4 enzyme pathway.
Which operates differently.
Right, it operates differently and doesn't get saturated as easily.
Because it shifts to a different metabolic pathway, the relationship between the dose you give and the amount of drug in the body becomes nonlinear. You might increase the patient's dose by a tiny fraction, but because the primary processing plant is already maxed out, that tiny dose increase leads to a massive, disproportionate spike in drug levels in the blood.
And that hepatic traffic jam leads directly to massive drug interactions. Paroxetine is a potent inhibitor of that CYP2D6 enzyme. It doesn't just fill up the toll booth, it essentially barricades it.
Oh, wow.
Any other medications a patient happens to be taking that rely on that specific enzyme to be broken down, they suddenly have nowhere to go.
So they just build up in the bloodstream to toxic levels.
Exactly. This is why clinicians and nurses must be hypervigilant. If you add paroxetine to a patient's regimen, you have to audit every single other medication they take to prevent toxic buildups.
Which brings us right to the front lines, the nursing interventions and the daily handling of this drug. And there is a twist in the clinical handling protocols that absolutely floored me. Paroxetine is officially on the IOSH hazardous drugs list. Group 3, Table 2.
It is a really jarring classification. We normally associate hazardous drug protocols with IV chemotherapy, not a standard daily pill for anxiety.
Exactly. But because the risks we've discussed, specifically the teratogenesis and reproductive toxicity, nurses are required to use gloves just to handle the intact, solid tablets.
And the precautions escalate based on the form of the drug. If a nurse has to crush a tablet for a feeding tube, they are required to wear eye and face protection to prevent inhalation or mucosal exposure to the dust.
That's intense.
And if they're administering the oral liquid formulation, the NOS guidelines mandate the use of double chemotherapy gloves and a protective gown.
Having to don double chemo gloves and a gown just to pour a liquid antidepressant into a cup is a stark reminder of the sheer chemical potency of these molecules. We treat them casually because they are prescribed so often, but they are incredibly powerful substances.
They really are. Beyond the hazardous handling, the vital nursing interventions revolve around vigilant monitoring. Nurses must track height and weight closely in pediatric patients due to that growth hormone suppression.
And suicide risk.
Of course. Relentlessly monitoring for signs of suicidality, especially during the first few weeks of treatment or whenever the dosage is adjusted.
So what are we teaching the patient before they go home with this prescription?
Patient education needs to be incredibly direct. Tell them to take it as a single dose in the morning. Taking it with food can help minimize those early gastrointestinal side effects like nausea. If they are prescribed the controlled release or CR tablets, they must swallow them whole.
Do not cut, chew, or crush them.
Never. And critically, they must not take the CR tablets with antacids.
Why not antacids?
The controlled release tablets utilize a specialized enteric coating and a polymeric matrix to slowly release the drug deep in the digestive tract. Antacids will alter the stomach's pH, prematurely destroying that coating and dumping the entire dose into the system at once.
Yikes. Okay, what about the liquid formulation?
For the liquid, they need to shake it vigorously and use a calibrated measuring device, never a standard kitchen spoon. Finally, caregivers must be explicitly educated to immediately report any sudden changes in behavior, agitation, or suicidal ideation.
We have covered a massive amount of clinical ground today, from downregulating cellular receptors to donning double chemo gloves. It is time for the Nursing School Priority Summary. We are going to synthesize this entire deep dive into 5 rapid-fire takeaways that you can take straight to your practice or your exams.
Let's lock it in. First, the must-know. You must know the black box warning for increased suicidality in patients under 24. You must know that IOH airs hazardous handling precautions, specifically the requirement for double chemo gloves when handling the liquid form. And you must remember its exceptionally high anticholinergic activity compared to other SSRIs.
Next up, the nice to know. It is frequently used off-label to successfully treat premature ejaculation, and the specific Brisdell formulation targets menopausal hot flashes, even though the medical community still doesn't fully understand the cellular why.
The test track. Do not crush CR tablets or administer them with antacids. And remember, it is highly contraindicated in pregnancy due to the severe risks of fetal teratogenesis and neonatal abstinence syndrome.
The clinical red flag, nonlinear pharmacokinetics. Paroxetine saturates and aggressively inhibits the CYP2D6 enzyme in the liver. This forces the body to shift metabolism to the CYP3A4 pathway, creating massive, complex drug interactions with concurrent medications.
And finally, your one-sentence memory hook.
Paroxetine, the hazardous SSRI that saturates enzymes, dries you out, and demands extreme caution with kids and pregnancy.
That distills the 80-20 rule perfectly.
It really does. But before we wrap up today, I want to leave you with a final thought to mull over. We started this discussion talking about the murky, imprecise world of psychological trauma and neurodevelopment. We rely on medications like paroxetine to bring a sense of balance to that murkiness, attempting to heal the mind by gently tweaking neurotransmitters. Yet when you look closely at the pharmacological reality, it is profound how physically brutal that process can actually be. A medication prescribed to ease a panic attack or quiet social anxiety is so physically potent that it can stunt human bone growth by suppressing pituitary hormones. It is so chemically hazardous that a nurse is required to wear chemotherapy-level protective gear just to pour a liquid dose. It completely reframes how we view a standard daily pill, doesn't it? The mind and the body are never truly separate, and the tools we use to treat one will inevitably and powerfully alter the other. Thank you for joining us on this deep dive. Keep questioning the medications you encounter, look past the brand names on the bottle, and we will catch you next time.